There you go, blue.
Okay. Do we have somebody on the line with us? Do we know?
Not yet.
Can we tell? Okay, well, hopefully they can hear me. So welcome, everybody. This is our seminar series for the Health Research Institute this will be its third year. So we're really excited that we still have many faculty members on campus to invite to come to our presentations. The goal of these seminars, for those of you who are maybe attending for the first time, was to try to bring together health researchers across campus and with our partners within the region to just sort of highlight and showcase some of the great work that's being done here in the North, and hopefully also to facilitate collaborations between people who maybe don't interact with one another on a day-to-day basis. I'm very fortunate to be part of the steering committee for the HRI and representing biomedical and clinical research. But it gives me an opportunity to sort of hear about some of the things that were going on. So myself and Chelsea Peltier and Margot Parks took it as one of the initiatives of the HRI to put on this health research seminar, and we started it, as I said, this will be our third year. So if you know of anyone who's interested in presenting, please pass their names to us. Otherwise, we sort of do it by word of mouth. For those of you who are attending in your coursework, we hope you find this to be a really open environment. We really appreciate having our students here. Please feel free to ask questions. This is not an intimidating environment. So even if you think, oh, I don't know enough to ask a question, I think that this is a perfect forum where our presenters generally welcome questions from all over the place. So with that, I think I'll stop there, and I just want to welcome first Darlene McIntosh. We're very fortunate to have Darlene, who is a cultural advisor with the CNC and elder with the Kwet'lutune First Nation, and she's here today to give us a traditional welcome to the territory here.
Hello, and it's in carrier, so you've learned your first carrier word, Hadi. So I'll get you all to stand, please. So it's introduction to the new school year. Some of us are a little bit ungrounded, a little bit, which direction do we go to until you settle in. So the first thing I want you to do is take a nice deep cleansing breath throughout your whole body. Nice deep breath. You need to learn to use your breath when things get out of hand or you into fear or anxiety. Breath, air was the first gift from Creator. It gave you life. The day you were born, you took your first breath, and the day you die, you will take your last breath. We breathe 70 or 80 years, and we never stop breathing. And what do you call that? Called a miracle. Each one of you are a miracle, and that breath helps you to connect with yourself at a deeper level. And when we do the breath, it grounds us into what's happening right now. It grounds us into this very moment. And how many times do we allow ourselves to be in the very moment, here and now, without thinking about yesterday, without thinking about tomorrow? So allow yourself that gift, that little momentary gift of connecting to yourself and being present to what's taking place. We, the Kwet'lutune Nation, have been on our traditional lands for over 9,000 years and supported by lithic evidence. The change that has taken place over thousands of years supports the enduring strength, courage, and fortitude of our people. Governance of the Batlas brought balance and harmony with our brothers and sisters of other First Nations people. Kwet'lutune's clans are Frog, Ceciliu, Grouse, Utsus, Beaver, Sa, and Bear Sa. Through this system, we know who our family connections are. Through our oral history, the use of legends told of our travel, our hunting and fishing territories, our trading practices with all peoples. May we remember and hold steadfast on what Creator's blessed us with and that is our traditional territory. Our ancestors have always welcomed people to our territory. On behalf of Clyde elders, our youth, community members, and chief and council, it is absolutely our honor to welcome each and every one of you to our traditional territories. All my relations must be thank you. Please be seated.
Thank you so much for that welcome. That's a wonderful way to start our seminar series off for this year. And actually, I mean, maybe my reflection on the first part where you said to be present is sometimes I'm sitting in my office or I'm working on a grant or a paper and I think to myself, oh, a seminar's coming up, I won't go because I've got to get this done. But actually the communication of what we're working on is just, it's just so, it injects so much life and sort of renewed energy for what you're doing in research. And I've always been very lucky to work in interdisciplinary areas. And even though I'm coming today to hear a seminar that's not related to exactly the work that I work on, it's amazing the amount of ideas that you get from listening to other people. So if you can take the time to come to these seminars or encourage your colleagues to do so, I would encourage that. Okay, I also realized I don't think I introduced myself in the hurry to introduce others. So my name is Sarah Gray, and I'm a member of the Northern Medical Program. And today I'm really fortunate to introduce a colleague of mine, Robin Root. So Robin is, I say she's part of the NMP because she's just down the hall from us, and she engages very much in the medical curriculum, helping our students in the areas of cultural competency and interprofessional education. Robin is the coordinator of clinical education for the Northern and Rural cohort of the Masters of Physiotherapy program at UBC. She is a champion for distributed medical education in the rural and remote context, and we're really fortunate to have her here at UNBC. She's also engaged in research, which is why she was invited today to talk to us a little bit about what she's doing in terms of her own research. And so with that, I would just like to provide a warm welcome for Robin and just to thank you very much for coming today. So.
Just before Darlene leaves, I'd just like to say thank you, Darlene, for coming. Thank you, and thank you for that welcome. And I'll try and figure out how to get this going. So thank you, Sarah, and thank you to the Leadership Council for the HRI. Thank you to Rochelle for organizing things. Thank you to Darlene for the warm welcome. It is a great pleasure to be here, and I still feel relatively new to UNBC. I've been here 6 years, but I still very much feel like I'm getting to know faculty, and I have appreciated coming to these seminars, although I've not been to a lot of them. I often get myself into Sarah's sort of place of, oh my goodness, I've got lots of things going on. But when I have, it's been incredibly enriching. And certainly, as Sarah said, I think the last one I went to was actually Sarah's. And although I am not a bench researcher with mice, I was fascinated by learning about what happens at Sarah's lab. So great. So my talk today is really a look at some of the work that I do, and I feel it's sort of couched in this sort of concept of 2 needs with 1 deed, really looking at how we can sometimes as academics, as researchers, really look at a problem and think about where the needs are and what we can do to solve them. And I often find myself in that place where, wow, we can do one thing and it's going to actually address a number of different things. So that's really kind of why my talk is, and hopefully that'll come through as we talk through today. So just a little bit of disclosure, I'm a senior instructor, as Sarah said, in the Department of Physical Therapy at UBC, but my feet are very firmly planted here at UNBC. I do travel back and forth. I'm hopping on a plane down to Vancouver to teach tomorrow, but I'm here. This is really where home is for me, and as many of you may know, we are really thrilled that we are developing Masters of Physical Therapy program out of here starting next August. And so that's a super exciting thing. So I have UNBC faculty appointments, both an affiliate through the NMP, but also an appointment through the School of Nursing and as an adjunct professor. So I feel very, very, very passionate about the North. And I remember when I first came to UNBC and one of the NMP faculty said to me, my gosh, you have all these hats and you're doing things, you're program developing and you're teaching and you're doing all these things. How do you kind of reconcile all that? And I said, it's really very simple. I have one passion, and that passion is to improve the health of folks who live in rural communities. And whether I do it through education, whether I do it through service delivery, whether I do it through health policy, program development, it all has the same thread. And that's really what brings me here today. And really, I hope what I want to share with you today is really how you can, if you have an aim, you have a purpose, how things start to actually move forward if everything is kind of aligning them. So I'm a clinician at heart. I'm a physiotherapist by training. I'm a bit of a reluctant academic. I've always worn a clinical hat. And when I ended up in academia, I was like, what am I doing here? So I feel a little bit lost sometimes in that world, and probably even more so lost in the research and evaluation and QI world. And so I really put those three together because I don't really feel like a researcher. I said to Andrea the other day that I feel like a quasi-researcher because like a little bit of research, but I have a little bit of evaluation and I do a lot of quality improvement, that kind of thing. But for the purposes of today, really what I want to share with you, I have a very close connection to and have definite biases and lens that I bring to the work because I am a partner in the actual development of this program, and I was a clinician in the program. I provided coverage, physio coverage for a year. So I really am very intimate with the kind of work that we're talking about today. So quickly overview, what I'm going to talk about today is really about gaps in the healthcare service system, gaps in the education system, and those are the two needs that I really thought out there and sought a program to address. And so I'll talk a little bit, perhaps for the benefit of students, about what does it look like to try and take on a project, whether that's a research project or a quality improvement project or an actual program development. What does that look like? And then how do you apply that academic lens and from my perspective, it was really that piece around evaluation and measurement. So I want to spend some time talking about that today to give you a little bit of an insight into how you can bring that experience that you have in academia to programs, in particular clinical programs. So we're going to talk through that and then kind of wrap it up through talking about lessons learned and takeaways. And please, like to make this interactive. It's hard to do, but if you do have questions, please do just jump in. This is meant to be informal. So how this all kind of came about, interestingly enough, was really community-based. And although, again, this isn't a community-based research project, it is a very community-based program development. So in 2015, a group of community members, some of whom were retired healthcare practitioners, some whom were patients, came forward and raised the concern to a number of individuals, myself included, that there was a real gap in the healthcare system with regards to individuals who had been diagnosed with a cardiac condition, had had a cardiac event, so that might have been a heart attack, it might have been some cardiac disease that required surgery. There was some event that happened that really changed their life with regards to, and they returned to the community or were in the community and returned, and there was no services available for them. The same is also true of patients in the community who had been diagnosed with a chronic pulmonary disease and really were confused about what kind of physical activity they could do. They were scared to do physical activity. There were no programs available to increase their quality of life. And so we really kind of saw that common theme around physical activity and improving quality of life. At the same time, we know the statistics show that COPD, so chronic obstructive pulmonary disease, which is a very, very common pulmonary condition, and cardiac arrest were the number 2 and number 4 reasons, respectively, for admission to hospital here in Northern BC. And so there was a really, really high prevalence of these conditions, and yet there was this big gap in services available to those populations when they've been discharged from hospital. And so we knew that there was a real problem there that needed to be addressed. We know from the evidence that, in fact, cardiac rehabilitation, which is a program that is designed to support people after they have had a cardiac event or who have cardiac disease and is designed to prevent further adverse events or to prevent mortality, we know those programs are very effective. There's lots of research out there to show that they reduce hospitalizations, that they prevent the reoccurrence of other acute events for those who have had a heart attack, their risk of having a second heart attack or dying from a second heart attack. So that cardiac mortality rate can be significantly reduced with a cardiac rehab program. We also know that there's health behaviors that, we also know that there's an importance of changing behaviors and some of the high-risk behaviors that contribute to some of these diseases. And so there's an opportunity to intervene to try and change that course and to improve quality of life. And furthermore, there's lots of evidence to show that it's cost-effective. So when we look at it compared to usual care, much less expensive than many pharmacological interventions as a result. And the same is true of pulmonary rehabilitation. So again, programs that are designed to assist patients who have chronic pulmonary conditions become more physically active, to be able to conserve their energy and be able to carry out activities of daily living much more effectively without getting an exacerbation of their condition. Left untreated, both of these conditions really result in a decreased quality of life. And so that's predominantly the focus of many of the research that are out there. So there's evidence to show that these two types of programs can be very effective. So armed with that gap that we know about, armed with the evidence, we started to think about the need to develop some kind of a program in this community that could solve that. I also, wearing the multiple hats, recognized that there was a real gap in our training for our students, for Masters of Physical Therapy students, in terms of knowing that there was a shortage of physios across the north and across northern and rural areas overall. So if we look at the stats for BC, we know that there's about only 6% of PTs working in northern and rural communities. And so we needed to develop programs that would actually see more students being trained in the north. And so we developed the northern and rural cohort in 2012, which had a mandate to increase recruitment and retention. And one of the ways in which we did that was to provide clinical education or training in clinical settings for those students in northern and rural regions. Part of the training, the clinical training that our students need to do, is in the area of cardiorespiratory care. So working with patients with cardiac disease, working with patients with pulmonary disease, which would kind of fall under that chronic disease management, and also to work in the areas of community health. So I recognized there was this gap in the healthcare system. There was a gap in terms of our education system, in terms of being able to provide clinical training, and knowing that clinical training in turn actually results in more of healthcare practitioners actually working in rural communities. So the literature around recruitment and retention shows that if we train healthcare professionals in rural communities, they're more likely to return to those communities. If we select students from rural communities and we train them in rural communities, there's an even higher chance that they're going to come back. And the more we do that, the more successful we'll be. We also know that overall, less and less physios are going into areas like cardiorespiratory, and yet that's an entry-level for our students, so we need to give them that opportunity. So really pulling these two gaps together was really the genesis for saying, let's create a program that fills that gap in service, but also provides training. So we developed a phase 2 exercise cardiac rehab program and a pulmonary rehab program that was run by students. Yeah. The cardiorespiratory.
Mm-hmm.
We're not taking those pills when they were. They need to. They absolutely need to. So in order for them to do that, we have to give them opportunity to do that. Although we have some core curriculum, we need that opportunity. So we were creating that clinical environment to be able to train. And because of the declining number of PTs in cardiorespiratory, there are very few of those placement opportunities. There's fewer opportunities for students to get that exposure, and we know that that's a bit of a chicken and egg. If we don't give them that opportunity to see what it looks like, they're less likely to go in it, they're less likely to actually be recruited. Thanks for the great question. Actually, it's a global trend. Oh, really? Yeah, very interesting. I think there are a variety of reasons. Some of it is that our students that are coming in are being exposed to more musculoskeletal and orthopedic conditions, both before they come into the program and when they're in the program, and so they have less interest in being involved in acute care. I think some of it is, in fact, we're seeing in hospital settings the complexity of many of the patients who have cardiorespiratory means that rehab often takes a bit of a backseat, or is really complex and people aren't interested in working. But I know certainly back to the question earlier, in our program, it's really difficult to ensure that all of our students have a clinic. They all get a simulated opportunity. They get exposure through simulation, so they don't often get real life experiences working. So together with the YMCA of Northern BC and with Northern Health, we built a partnership and we developed this cardiac and pulmonary rehab program. And essentially, we modeled it after best practice guidelines in the literature, of which there's not a comprehensive one for pulmonary rehab, but there certainly is for cardiac rehab. And so again, bringing a bit of an academic lens to the program, I was able to provide some direction on how to design the program so that it was using what we know in terms of evidence in the literature. And so what it ends up looking like is a 10-week program, happens 3 days a week for the cardiac program and 2 days a week for the pulmonary program. We have our students supervise patients while they are exercising. So if any of you know anyone who's had a heart attack or anyone who has a pulmonary condition, perhaps they're on oxygen, it's very difficult for them to exercise, and it also can be quite scary. And so our students provide patients that support and being able to develop an exercise program that's appropriate for their level. After doing extensive intake assessments and initial assessments to determine where patients are at, we can design that program and support them appropriately so they'll be successful. The other component of these programs is education. So we do a lot in terms of really providing education to patients about how they can modify their lifestyle, their behaviors, their health behaviors to reduce their risk of further event or exacerbation of their pulmonary condition. Those sessions also include, we often bring in experts like dietitians or pharmacists into the program to provide that information to participants to how to sort of better their quality of life overall. So the program is run by a physiotherapist, an exercise physiologist, and by our students. Our students are out on clinical placement 30 weeks a year, so there certainly are some downtimes when there are fewer patients in the program because we in fact have fewer bodies on the ground to supervise those patients. But the physiotherapist and the exercise physiologist are there full time. The number of patients that we can have in the program does depend entirely on bodies that are there to be there for supervising. So we assess every patient when they come into the program to what their level of risk is really associated with their condition. So if someone has very recently had a heart attack and they have a high risk for having a reoccurrence of a heart attack, they need to be monitored much more closely while they're exercising as compared to somebody who may be at a much lower risk. They have fewer risk factors. They may be more stable in their condition. We can get their heart rate higher without being concerned. So they don't need as much supervision overall. So the ratio of participants to staff really depends on their risk factor. And that's a really great learning opportunity for our students to be a part of what we call risk stratification. So really taking into account someone's full medical history and then being able to use their skills and knowledge around exercise physiology, what's most for this particular individual. We also have a pretty great connection with a lot of the physicians and specialists in the community and get referrals from across the board, as well as from some of the hospitals outside of Prince George and elsewhere. And our students, again, that's another great opportunity for them to be liaising with the rest of the healthcare team and the rest of the healthcare system overall. So it really has been a great learning opportunity for them. So how do you go about, I thought I'd just spend a couple of minutes just sort of sharing with you about how do you go about starting a program when you find these kind of needs and you have these ideas, what do you do? So we pulled together a bit of a steering committee. So we contacted cardiologists in town as well as the respirologist and said, we have this idea. This is what we're thinking. Will you join a steering committee to help pull it together? And they said, for sure, this is what our patients are crying for. We know that this is what our patients. So they were more than happy to participate. We pulled together a bunch of stakeholders, including those community members who came forward to us. So the patient and hired critical care nurse that came to us and said, there is this gap in service. So we reached out, we found some other patient partners who are currently, would be candidates for this program, as well as those initial community advocates. And we formed a bit of a steering committee to help design the program and to be able to actually say, how are we going to make this happen? A big part of that, as I wear my academic hat, was to say, if we're going to do this, we need to make sure that it's going to work. And we need to be able to measure that it works, because in the long run, someone's going to have to pay for it. And so healthcare always comes down to dollars. So we developed a pretty elaborate evaluation framework to be able to show that at the end of running it for 2 years, that it was a cost-effective way of delivering service and that we could save the system money if, in fact, we had a program like this. As I said earlier, we based it on Canadian guidelines, and within those Canadian guidelines, there are some quality indicators. So really, this became really a true quality improvement project. Share with you a little bit about what that looked like. So the evaluation framework that we developed, we spent a long time. So before we even got the program up and going, we spent a long time. Because we knew that this was going to be key to us being able to sell it back to the health authority to say, this was a really good idea. We think you should consider it. And so we looked at everything from the structure of the program to the process, and then importantly, but not to be kind of overemphasized, was the outcome piece. So the structure is actually things like wait list. How long do people have to sit on wait lists? And what does the evidence say about when you need to intervene? And there's some really good evidence out there, in particular in the case of patients who had some kind of cardiac event, that they need to start exercising and exercising at a relatively high intensity within 6 weeks, no later than 6 weeks. So we needed to make sure that our process was seeing the patients at the right place at the right time, and we needed to measure that. So we put in things like that into our evaluation framework to help us be able to ensure that we were meeting those quality indicators. We also really wanted to know lots about what we were actually doing, the type of interventions we were providing, and whether we were actually being effective in doing that. And then finally, we really wanted to look at outcomes. We wanted to look at the patient outcome, and to make sure that we were making changes in the patient, we also needed to look at healthcare utilization and whether the program was having an effect on the healthcare system overall. So I'll just delve into a little bit of each of those for you and go into them. So in terms of the outcome piece that we'll talk about, we looked at exercise capacity for the patients that came into the program. So we used a number of different outcome measures to be able to determine their aerobic capacity, or really what level of physical fitness they were at. We looked at their disease state. So who were the patients that were coming into our program? What was their overall sort of level of acuity? And there's a number of different measures for that. And we looked at risk factors. So we know that there's a large number of risk factors that we can modify, and that will then, as the name would sort of say, reduce their risk overall of having a further event or leading to mortality. We then looked at program outcomes, as I said. So we really were interested in that whole number of referrals. Were we getting the right referrals? Were we, what was the length of time from the time we got a referral till they started the program, and from when the referral happened relative to when their event happened? We wanted to know a little bit about whether they were satisfied with the program and what the program attendance was and their adherence. So we implemented a number of measures around that. And then we looked at system outcomes. So what we were most interested in relative to those statistics that I started with at the very beginning was we were interested in the number of admissions to the emergency department at UHNBC for folks who had had poorly managed cardiac symptoms or who had exacerbations of their pulse. We also wanted to know if there were being less admissions to the hospital, and we were actually also interested in the length of stay once they were in hospital. So right from the get-go, we had to develop these evaluation measures and then figure out how we were going to collect that data. That was one of the more challenging pieces. We know we need to do this, but how are we going to actually do that? So in designing the program, we in fact use students to do this. We had students come up with and do the research on finding these outcome measures, on developing the outcome measures, putting them into formats that we could either have clinicians fill out or patients fill out, and we all adopted the electronic medical record because that allowed us to collect some of the data that would help us in the long run be able to track it over time. So that method of reporting and sources of data was a really important piece before we even got started, because we knew we needed to embed that in the design of the program. So just a little bit about what we found, to kind of share some of this with you, and I'll tell you a little bit more about how we found it. So pretty exciting. In the first 2 years of running the program, we actually found that we increased the aerobic capacity or the fitness of our patients by a statistically significant amount. So we use a number of tests, a treadmill test and also a 6-minute walk test for patients with pulmonary conditions. And we looked at those measures of when they started the program and 10 weeks later when they graduated the program. We noticed overall they all made improvement, and they all made improvement by a pretty significant amount for them. For somebody who has, it may not seem like a lot to you, 62 meters of an increase in walking over 6 minutes, but for somebody who is on oxygen and who has a pretty serious pulmonary condition, that's the difference between parking right next to where it is that you have to go into the grocery store and then having to sit down before you do your shopping versus I can get from my car to the door of the grocery store and walk around the grocery store and come back out again. That's the difference in quality of life. So these may, again, not seem like big numbers to those of us who think we can walk for 6 minutes with no problem in long distances, but these are pretty significant amounts for folks that have conditions that are really affecting them. And the same with patients who have cardiac conditions. So MET stands for metabolic equivalent, and that is a measurement that we use in exercise physiology to look at someone's overall aerobic capacity. We also looked at self-efficacy, which was really the ability of folks to be able to manage their condition and manage navigating the healthcare system, and we saw an improvement in there, although there's not a lot of literature as to whether that was an effective, statistically significant improvement. What we did see was a statistically significant improvement in levels of depression. And we know that depression is pretty significant with both cardiac conditions and pulmonary conditions, and we made definitely a difference in those folks who had cardiac conditions. What this information also tells us is we probably need to do more work with regards to education and with regards to maybe getting other resources for the participants in the program around depression, because we need to even make a bigger, stronger. And the same with anxiety. Really change anxiety amounts overall with the participants. So we probably need to do more with regards to our education program around that. Overall, folks were really satisfied, which was great, and they recommended the program, which is good, but it makes our wait list longer. So always twofold problems with that. Some great testimonials from patients. So we had our students collect some qualitative data around the patient's experience in the program and ways in which we could improve it overall. So in general, people really talked about increasing confidence and setting goals that were attainable, and previously feeling that life was not attainable, or having a quality of life was not attainable. And really patients saw that the rest of their healthcare team was also satisfied with their participation in the program. And so that was really pleasing to see that, in fact, folks felt that the program was really valuable, felt that it was really important to their overall journey through the healthcare system after being diagnosed with a pretty significant. I'll share with you a little bit about the system outcome pieces, and we're still working through some of this, but I think it again is valuable. So what, as I said, we wanted to really know were things like admissions to the emergency department and hospitalization. So we worked with Northern Health to have access to their database, which tracks patients who come into the emergency department. And so because we have an electronic medical record, we could actually pull information about our participants for 1 year before they came into the program to know how many times they went to visit the emergency department for their cardiac condition. We weren't interested if they had other reasons to go to the emergency department. We just wanted to know how many times did they go because of their cardiac condition or because of their pulmonary condition. And then we wanted to look at the 6 months or 1 year post-participation in the program. Did it change the number of visits to the emergency department? Did it change the number of hospitalizations they had, strictly related to their particular condition? So we collected that data from UHNBC's emergency department and also from their overall admissions into the hospital. And we found some pretty interesting results. So as I said, the pre would be for the 1 year before they came into the program, and the post would be for 6 months or 1 year after they left the program. So we collected the data at one point in time. So some people had been out for 6 months from their program, and some people had been out from about 1 year. So it varied slightly there. But for the 20 inpatient encounters, we'll jump to the next slide so it will be easier to read. So in terms of inpatient encounters, so admissions to the hospital, we had overall about a 75% reduction in the number of admissions to the hospital. So for the 16 patients that were actually admitted to the hospital for the 1 year before they participated in the program, there were a total of 20 encounters across those 16 patients. After the program, only 4 patients were admitted to the hospital for their cardiac condition, and there were only 5 encounters out of that. In terms of once they got into the hospital, we also noticed a 85% reduction in bed days and 41% reduction in length of stay. So significant difference there in terms of how long they spent in the hospital and the actual time they spent there. So again, same thing, you can kind of see a big difference in that amount. In terms of the emergency department, we saw a 25% reduction in the cardiac, which is not bad. It's not great, but it certainly is a smaller number. And so what we have done as a result of that is we're working with Northern Health and their cardiac program to see patients that have certainly been admitted to hospital at least once go through the cardiac rehab program, because we know over time it can actually reduce their readmission to the hospital at a future date. The numbers for pulmonary rehab, and certainly the literature would echo this as well, was even more significant. So we really, probably the biggest difference we saw was actually in the amount of patients who had pulmonary conditions who participated in our program, really reduced the number of exacerbations they had of their condition, reduced their emergency department visits. So you can see overall, out of 15 patients who had had 28 encounters with the hospital system before they participated in the program, only 4 patients had 5 encounters afterwards, so an 82% reduction there. And what we do know overall around all of these numbers, we don't have it for cardiac, but it's very clear for is that generally when someone gets admitted to the hospital for an exacerbation of their cardiac or their chronic obstructive pulmonary disease, it costs about $6,000 for that particular encounter at the hospital. And so that's just an encounter, not the number, that's not per day, that's just what it costs for them to actually show up when they have an exacerbation of their pulmonary. And so if we look at the data overall, we can see that there was pretty costly for the patients who encountered the 28 encounters prior to them being admitted to the, or prior to their participation in the pulmonary rehab program. So potentially costing about $185,000, whereas after they participated in the program, because we saw that significant reduction, 82% reduction in their number of encounters with the hospital after they participated in the program, it cost a lot less overall. So a big savings to the health authority. And so although we actually never did anything further than kind of these numbers with the cost, this was enough for Northern Health to say, it is saving us money to have a pulmonary rehab program, which essentially costs 2 staff members and a little bit of space. There's very little other, because we have partnerships across with the Y, et cetera, there's very little cost with running this program. So it is a huge cost savings to the system overall by having patients not be presenting at the emergency department or in the hospital as a result of their condition. Okay. So we looked at, after 2 years of running the program, we presented this data back to Northern Health, and they were pretty convinced right away that it was a valuable program and worth doing. So that was kind of one angle of it. The second angle of it was, of course, having students participate in it as part of their clinical education. And what we did again here was to evaluate students' participation as in this student placement, and overall the results were they felt much more confident and in fact were much more competent around some of the skills that they needed to meet as part of their training. So in particular, taking vitals with patients. And although the comment that came out of this for students was, you know, we take vitals of patients all the time when they're lying in bed or when they're sitting nice and still, but when you're doing it while someone's exercising, while they're hooked up to oxygen, while they're in a panic state around their condition, was really challenging. And that really helped them to give them the opportunity to hone their skills. And also skills around critical thinking. So because this is a relatively acute population who are relatively unstable, it really gave students an opportunity to really think through some of their clinical. They also really, the students were in charge of running all the education sessions for participants, and that was a huge learning curve and an opportunity for students to really learn about self-management and how do you work with patients to change their change to having more healthy behaviors overall once they even graduate from the program. So some of the feedback we got from students were things like, it was amazing to watch the attitude change and gains in confidence over 5 weeks. So each clinical placement is 5 weeks, so students would see patients for that particular length of time. And we also found that our participants and our patients in the program were really thrilled to be working with students. They really enjoyed that aspect of it, knowing that they were helping to contribute to future healthcare professionals and the training of future healthcare professionals. So that was also a really positive aspect of that. We also built into the student learning experience quality improvement, because we were, I think this is sort of like the dual hat piece, in that we were in fact running a quality improvement project around this to be able to prove to the health authority that this was a valuable program. And we wanted students to also gain the skills in how you did that. So we had all of them involved in team-based projects around things that they actually, we needed to gain information for in the project. So in 2017, we had them look at physical activity 3 and 6 months out from the program. So we had them be able to see what participants were doing when they left the program, what kind of barriers they were facing, and what we could do in the program to ensure that when participants were discharged, they were carrying on their physical activity overall. What they found was that 3 to 6 months after the program, about 54% of patients were actually meeting the Canadian guidelines around 150 minutes of exercise per week. Now, I'll just tell you that it's only about 12% of Canadians actually do this. So the fact that 54% of participants are doing it is pretty fantastic. That's better than those of us in this room, maybe. So that was really positive, but it also says to us we do need to do more to make sure that even more of our participants are carrying guidelines after. They also found, not surprisingly maybe, that there were some barriers to participants continuing on with physical activity. Weather was one of them. Ill health and fatigue, which of course, not too surprising, having more complications associated or a pulmonary exacerbation associated with their condition, and that motivation was a bit of an issue. But we felt that we could help, potentially, with some of those barriers. So the second project, the next year, was to design tools and resources to be able to give our participants more support when they graduated the program to meet those levels of physical activity. So they came up with developing a handbook. Should have brought it today, sorry. So it was a very useful resource that actually looked at each of those barriers. So if weather was a barrier, then they actually had a list of a number of places here in Prince George where you could exercise indoors, like you could go to the mall at this particular hour before the doors opened and you could walk, or you could participate in this particular program. If you had trouble getting motivated, here are some things to help you with that. Develop SMART goals. And with each page of the book kind of corresponded with the barriers that had been identified by the previous group of students that were preventing patients from actually participating. So that book is now a handbook and a resource for the program that students developed. Last year, a group of students wanted to find out, there's increasing research being shown kind of around the type of exercise that patients are involved in cardiac programs. And they were also really interested in whether there was a difference between the different risk factors associated with cardiac patients and how they did in the program. So they did a number of detailed statistical analysis on the data that we have of patients in the program to look at whether their improvement in exercise tolerance was related to their cardiac condition, and in particular, how efficient their heart was. So we have measures that come from stress tests when patients undergo stress tests to look at what's the efficiency of their heart, their ejection fraction as it's called. And we looked at those values and we looked at how they did in the program, and we looked to see whether, in fact, we should be modifying the type of exercise that those particular participants are doing. There's research to show that high-intensity exercise for short periods of time can be really beneficial to some of those population or some of those cohorts of patients. And so they looked at that and in fact saw that our participants were doing much better than the literature shows with regards to how much improvement they're making, even doing this continuous moderate intensity exercise. And so we were doing better than the literature showed this type of exercise would do. So perhaps we're doing okay, but maybe there's also room to explore, could these patients do even better than that if, in fact, we change the type of exercise we're doing? And so I wouldn't be surprised if next year that's the research project that we have our students involved in. We also wanted to see whether we changed any of the other risk factors to a significant kind of level. We knew that a little bit, some of them have changed, as I said, overall, but so the depression scores showed statistical significance in their improvement, but anxiety didn't, and stress levels did change in their ability to cope overall. So really, I think what we wanted to demonstrate to students as part of their clinical learning was that it's an important skill to actually know how to do quality of improvement on a project and to be involved in that evaluation aspect of a project. When you're a clinician, you often think just about what you're needing to do on a day-to-day basis with patients, and you don't often think about those bigger and higher level skills that you may need to be able to either demonstrate that a program is really effective or that you are in fact improving patient outcome overall. So I think this was, again, that concept of two needs and one deed. Having students involved in the clinical placement overall gave them an opportunity to learn not only the clinical skills, but also quality improvement skills. One of the most exciting outcome pieces for us as part of the education is that, as I said at the beginning, we know we have a shortage of physios across the north. And it's really hard to train physios if you don't have physios to train those new physios. It's a bit of that chicken and egg problem. And we had a significant problem actually filling the physio position for this program, which is why I, as an instructor, ran it for the first year. And then we had a number of local physios fill in because we couldn't actually fill the physio position. But one of the graduates from the very first year of when we ran this program, and who was one of the very first students to participate in this clinical placement, is now the physio for this program. So once she graduated and had a little bit of experience under her belt, she's now hired Sandy Kennedy to be the lead physio and is in fact taking students and continuing the project on. So I think we're seeing that certainly, all in all, this is a really effective program, again, at being able to offer those placements to students and in turn address recruitment and retention. The Northern and Rural cohort overall has shown some success in that if we develop clinical placements in Northern and rural communities, we select the right students to come into the program and do those clinical placements. Right now, our stats show about 43% of our graduates are working in Northern and rural communities. So a significant improvement from if we didn't have the program. We know only about 7% of the Vancouver graduates are working in Northern and rural communities. So overall, we're seeing that we're actually making a difference there in terms of the physios working outside of the Lower Main. We've also seen an improvement in the number of physios actually working in Northern Health, so they're happy to continue to be partners with us. We don't have stats about whether this program is making a difference to the number of physios that are working in cardiorespiratory. It's something I'm thinking about how we can kind of look at and measure over time. But as I said, we certainly have one physio who's gone and worked in that area. So we've made one improvement. So that's a start. So yeah, again, I think we've shown a bit of overall. So lots of successes in this program. We've demonstrated statistically significant changes at the patient and at the program outcome level. And we've probably exceeded some of those outcomes with regards to the impact that you can make in the healthcare system overall, like the cost savings and the cost effectiveness we've shown. And I think we've also provided it being a really valuable training opportunity to address recruitment and retention. We're now looking, in partnership with Dr. Pelletier here, we're looking at now how we might be able to expand this a little bit and have this program support more regional programs across the north. So we've been talking about developing a way in which this program could support a program in Paris, how it could support a program in Fort St. John. So we're thinking about that, whether that also might include telehealth. We're going to explore ideas around that. So I think overall, and I hope, you know, as students, if you're kind of thinking about research projects and thinking about ways in which you might want to be involved in a research project, or if you've got one on the go, some of the takeaways I would encourage you to think about from today is really look at partnership, look at ways in which you can address multiple needs by doing something. So think about who partners can be, who stakeholders can be. And I think those of us that are in academia, I think we have a social responsibility to look at where some of the needs are of the population and how we can, I don't want to say use students, but in a way, how we can actually harness the energy of students and harness our mandate around education to ask questions and to develop some of these programs that have both the lens of training and have research and really positive outcomes for the health of the population. Big piece of advice I would always say to people is if you're going to embark on things, really spend time up front looking at that evaluation plan and really building a structure that you know in the long run is going to be able to show you whether what you're doing is effective. I can't stress that enough. It feels really boring and you just want to get on and get things out the door, and as a clinician I just want to see patients, but instead, if you take that time to actually build that evaluation plan, it really pays off in the long run. Commit to using the data. I'm guilty of this, and this is really more a message to me, and that I collect lots of data all the time, but I don't often have an opportunity to use it, and so I'm now getting a bit smarter and saying, well, students can use it as part of their program. So, and certainly this is where often coming to things like the HRI to be able to look at where your partners collaborate with others to, use some of that data, that would be great. And the same goes for the knowledge translation aspect of it. You know, there's lots of opportunities to partner to try and get that word out there and then put some of this evidence into practice overall. I think that's all I have to say. So, any questions? Anything that I keep wandering out of camera, right? Is that what you're? Any questions? Any thoughts? Any comments?
Great. Are you still with the program?
So we are still doing the outcome measures. We're collecting all the data from the outcome. We've not run an analysis with Northern Health databases for a while since that first 2-year pilot. So we did that in 2018, and we haven't done that since. But it's there to be, so we've got all the processes in place. If we wanted to run it again and see what the system impact was, we could do that because, again, it's all in place.
Yeah, and so then just with, in like sort of related to that, so you did a pre and a post admission. So what was the criteria for referral to the, or what is the criteria for referral to the program?
Yeah, great point. So the criteria for admissions to the cardiac program is having had some event or surgery related to cardiac condition. So it's not a prevention program. So if you just have cardiac disease, it's not designed for you. But if you have cardiac disease and you have or you have surgery to have a stent put in and you didn't have an MI, or if you have a CABG, then all of those people are eligible. People who are not eligible are people who've had a recent pneumothorax, who have unstable angina or undiagnosed, or pulmonary hypertension, sorry. For the pulmonary population, it's anyone who's been diagnosed with a chronic pulmonary condition, anyone, and it has been diagnosed. So we don't want people who have an unknown pulmonary condition.
I mean, clearly you're showing improvement. I just wondered if it would be worth also looking at like a control population from this demographic to say those who have not been through the program, whether you're like,
very good point,
from when you would have been referred, but you didn't go into the program, what was your pre and post? I mean, you're already showing major, but I feel like that would be a nice comparison to say in this demographic thing that whatever is out there for others. You know, whatever else. Anyway, really fascinating.
That would be really neat to do. It's a good suggestion. I'd have to think about. I mean, there's certainly many communities that do not have this program, right? And so even using a cohort from other communities didn't have access to that care is what I'm thinking. But yeah. Absolutely.
But even
you could do a control group. Might have control,
years before we.
Yep.
I guess I just sort of, as a researcher, obviously,
Great.
It's like huge for quality improvement here, but I feel like that, and I don't know I'm making an assumption, but I feel like a lot of the data that's probably published about programs like this may come from urban centers, whatever. So if it can get into the literature, I think that it can be very supportive for other communities with similar demographics, similar barriers, like whether, whatever it may be. So, just as the numbers increase, it would be nice to get it out there. And there's an example of sort of a mid-sized community in northern.
Great. Yeah, I'd love to. And if there are people out there who are thinking, oh, I would like to be involved in that, that'd be great, because that is too much of a research hat for me. That would not fit very well, but I'd be very happy. Great. Yep. Yeah, for sure.
Right now,
we're just doing moderate continuous.
So I think that you have an option that they could do intervals and people like our baby little project. But I think that's what most of the high intensity for it as an option, but not everyone wants to do it. And it's safe. And evidence that's safe.
Yeah, absolutely. And because we've now been a little bit better at collecting data on that left ventricular ejection fraction, we can now kind of put people into cohorts to their fraction. And we know that the literature around high intensity training fits some cohorts better than others. So yeah, for sure. So if you have a student who'd like that to do as a project, certainly be, certainly.
Yeah. For the pulmonary program, does that include patients with bronchiectasis?
Yes.
And CF patients?
Yes.
And asthma patients?
We haven't had any asthma patients through, actually. The majority of our referrals from for the pulmonary program have come through the respirologist. And so, yeah, interestingly, we haven't had a lot of. Yeah, great question. So that really varied over the course of the program, because when we initially started, we had patients who had an event 2 years ago and that were now being referred to the program. As it's gone on, we have worked harder and harder to capture that population within the first 6 weeks. And so it is looking much better. We're much better in that quality indicator, but initially it was really awful. Yeah, so I think, again, that was sort of one thing that we were working on really hard when we advertised the program and sort of got communication out to physicians initially. We realized we were getting more of the kind of chronic stuff. And so doing another education campaign around, we actually want patients in this period of time, where are they? Why are they not getting here? And we realized that, in fact, we shouldn't have been relying on the family physicians to get them. We needed to involve the actual hospital discharge person to be doing a referral. So then it became a whole connection that needed to be looked at. So yeah, great question.
So we should find out. Do you have any idea how can we, as you know, mostly they think about the cost and they don't want to participate. Like, what's your idea? How can we encourage them?
Yeah, I think often it is really what's in it for me, kind of answering that question. So put yourself in the shoes of your partner that you're trying to partner with and say, you know, what are they going to get out of this? And so when we had initially gone to Northern Health, we said, we actually just want you to endorse the program. You don't have to be involved. You can just be there, but this is, in the long run, this is what you're going to get out of it. So I think sometimes that strategy of just being able to sort of say, are they going to say it's going to cost too much, it's going to be too much work for me? So what can you do in the design piece to say, well, actually, no, all I want you to do is lend your voice or to this or to endorse this, or well, I just need your expertise to sit on the steering committee. Don't need you to actually be involved. That's my role as the program developer or as the quality improvement designer or whatnot. So I think really trying to, I often say, sort of get things to a polished enough state that when you present them to somebody, it's really clear what their role is going to be and what they're going to get out of it. Yeah. Online. Great. At Fort St. James. Yeah. Stewart Lake. Hope. You know that area. Yeah. No, I was like Sean, that's Sean's favorite place. Oh,
I recognize her.
You recognize.
So how do you graduate from the program? Like you were saying about when they leave the program, you have a 54% sort of patients who are still meeting guidelines. So is it just a timed thing, or do they need a certain?
No, it's a timed thing. So the program is 10 weeks in length. So as a participant, and it's actually 10 weeks, kind of purposely set out in that we say to patients at the end of 8 weeks, you can discharge yourself, or you can continue in the program for another 2 weeks, but we're not going to be monitoring you as intensively as we have been for the first 8 weeks. We want you to sort of taper into self-managing. So you can continue to participate, but we're not going to be monitoring you nearly as closely. And at the end of that 10 weeks, they should have met their sort of improvement from where they came in. And we are seeing that. So I think the literature has, again, sort of suggests that 8 to 12 week time frame. And so we have given volume of patients that need to go through the program. We haven't said you can stay on as long as you want. It's just you need to graduate. You need to self-manage on your own. Yeah.
What is the cost of access? Is it covered, and was it physio sometimes is an extended benefit for the state? And so because of issue, was it easy to get it covered? Like, how does that look on your end?
Yeah, great question. So that was part of our initial program development design, and we had a lot of conversation with the steering committee about that when we first designed it. We all felt very strongly that we needed to minimize barriers to accessing this program. And so one barrier was transportation. We needed to locate it in a place where people could get to. And another barrier was finance. We know that, exactly as you say, that often physio is not covered under the healthcare system, and it's only available to those who have third-party insurance. So we actually, in partnering with the Y, talked a lot about this, and we decided, let's try and make it a one-time fee of $10, which would cover the administrative fee of registering them at the Y to be able to access card to get in and out of the Y. So we had a one-time fee of $10 so that there would be no financial barrier to participants coming to the program. And we didn't have any complaints from folks about money. No, that was good. So obviously finances wasn't a barrier. But what we actually noticed over time was that in that study that we looked at the 3 and 6 month follow-up to participation, very few people were actually involved in community activities. Most of them were exercising independently. And that's fine, but that's probably why we only see about 52% meeting. And the literature would say that if you're part of a social environment, if you're part of some kind of an organized activity, you're more likely to continue it over time. And so we took advice from a lot of other cardiac rehab programs that have a membership fee or who have an actual amount and who have no problem, they have lots of participants and finances don't seem to be a barrier. So we thought, okay, maybe the issue here is we're not getting commitment from our participants who, they're committed to come to the program, but they're not committed to continue the program once they're done. And that commitment once they're done might be financial. They need to actually put out some money to continue to be physically active once they graduate. So when we, after the first 2 years of data, we then instituted a membership fee at the Y. So now participants have to get a membership at the Y to be able to participate in this program. And that membership is on a bit of a sliding scale, but on average, it's about $30 a month. So participants are in the program. So it's about $80 for them to participate. There are subsidies available through the Y for folks who cannot afford that. And there are family memberships that participants can take out or go. And what we've seen since then, although we haven't run data on it, but anecdotally what we're seeing is that more participants are continuing to exercise at the Y after they've graduated from the program. Potentially, also at other facilities, because they've already had a layout of, they're willing to continue to exercise knowing they're going to. And just as we were talking about yesterday with Sandy, there are certainly folks who pay very, very little to come. So the subsidies are there for those folks who cannot afford it. So we are pretty confident in that financial barriers are not there for this program, that we're continuing to do it. But at least we're, maybe getting better.
The cost of programs are covered for the pastors.
And Northern Health, that's right. So the 3 partnerships continue to support the actual program overall. So the physiotherapist is hired by the Northern Health, the exercise physiologist is hired by the Y. Students, of course, come through here, and we provide sort of infrastructure, or not the infrastructure, but the actual program structure support.
Amazing. Thank you so much, Robin. So thank you so much. Thank you so much. So we will continue to have these seminars. I think I'm getting confused because we switched the day. So it's second Thursday at 2, we're going to try for this semester. The next speaker is Dr. Travis Pollock, who's from the I'm going to get his title wrong, but anyway, Executive Director, Research, Primary Care, and Strategic Initiatives at, is that right? About right? Something like that, at Caries County Family Services. So, yeah, it'd be great if people can come out again, spread the word, and I think Brianne will send out an invitation widely to the listserv. So anyway, thanks again, you guys, for coming and for engaging in conversation. So you can sort of see the format. We usually have a formal presentation, usually pretty casual in that you can interrupt, ask questions, lots of questions after. So yeah, great. And we look forward to seeing you guys again. Thank you. Thanks again, Harley.
You put some other slides on here, sorry.
That's great. That's amazing. It's just